Dear teachers, let me first thank the Malappuram Surgical Club for this initiative and also the invite to talk on very important topic on recent advances in rectal cancer surgery. Let me first tell you that most of the slides are from my colleague, who is Dr. Dilip Damodaran, who takes care of our rectal cancer services and is probably our bill healed in our hospital. So without much ado, let me go into the topic proper. And most of the advances in rectal cancer surgery over the century has been evolving with the main aim of improving the oncological outcome and also improving the patient's quality of life. Over the century, better understanding of the tumor, its behavior, has all led to cultural changes in the way rectal cancer surgery has been done. And these changes are not just by developing the technologies, but they're also by having great intuition by some rectal cancer surgeons. And this has helped in making rectal cancer surgery very respectable and safe for the patient. So if you see the timeline, you can see from 1907, Ernest Miles first did an abdominal perineal resection with a curative intent. Before that, rectal surgeries were done with palliative intent, and it was Ernest Miles who first did the abdominal perineal resection. It was a low ligature with a low ligature of IMA, and he did with a radical intent. It was a morbid procedure, and in 1907, his survival rate was at 1 year was 58%. By 1923, he perfected the technique. He understood much better, the morbidity decreased, and then reached a respectable 5-year survival of 30 to 40% by 1923. Lord Moynihan in 1908 did the abdominal perineal resection with high ligature. And it was Moynihan's saying that surgery for any malignancy is not surgery of the organ, but it is a surgery of the lymphatics, and it holds true even now. So he's a visionary who thought that it's the lymphatic spread which causes recurrences and also probably the death of the patient. So he devised the abdominal perineal resection with high ligature. Then Hartmann from Germany, he wanted to reduce the perineal morbidity, so he did a Hartmann's procedure, which we commonly do for emergency situations, and he just removed the tumor, the mid or upper rectal tumor. He removed the tumor and put a permanent colostomy. Then it was Dixon in 1958 from Mayo who devised the anterior resection. At that time, people thought that anterior resection was a non-oncological procedure, but in annals of surgery in Quebec, he presented his results, and it showed an impressive 5-year survival of 64%, much stronger than the criticism and skepticism of the surgical fraternity at that time. Then over the years, people started learning more about rectal cancer, and it was Golliger and Dukes who looked into the pattern of spread of the rectal cancer, and they said that only 2% of the rectal cancer spread beyond 2 centimeters. And they analyzed 1,500 specimens and found only 2% having spread beyond 2 centimeters. And then they said that 5 centimeters is a reasonable radical margin for rectal cancer. And this margin changed very rapidly and has come down to even less than 1 centimeter now. Then it was Parks who devised the low anterior resection, which you commonly do. Ravitch brought the staple anastomosis. Then it was Lesorth who formed the colonic J-pouch, and also he's also credited with devising the intersphincteric resection. Then the golden boy of probably the rectal surgery is Bill Heald from UK, who made rectal surgery very safe and respectable by presenting the TME approach. Then it was Buse from Germany who devised minimally invasive procedure for selective tumors by transanal and endoscopic microsurgeries. And then autonomic nerve preserving to improve the quality of life, erectile and bladder dysfunction, to reduce bladder dysfunction was devised. And then a lot of technologies came in about laparoscopy and robotic platforms. And this was slowly, this is how from 1907 to over to 2010, rectal cancer surgery evolved. So my talk would be, I divide the talk into surgical advances, technological advances, and advances in adjuncts to surgery. So before that, these are the 6 pioneers. From the top right is the Ernest Miles, who devised the Miles operation of the abdominal perineal resection. Then next is the Hartmans, who devised the Hartmans procedure, and then comes Dixon, who devised anterior resection, a very safe, and now we know it's an oncologically safe procedure for upper rectum rectosigmoid lesions. Ravage brought the staples and made anastomosis easier and also decreased the leak rates, and Buse produced minimally invasive procedures of transanal or transanal microsurgeries, and Bill Heald, who proposed the concept of TME. So coming to the surgical advances, the journey from Miles to TME and beyond was possible with understanding of the pathological spread, as shown by Golliger, who said that only 2% of the tumors spread beyond 2 centimeters. Immediately, people started looking further, and they said that the 5 centimeter margin as proposed by Golliger was not necessary, 2.5 centimeters is enough. And by 1980s and 90s, people again reduced it, and in the late 90s, 1 centimeter margin, distal margin, is enough for a rectal cancer. With the advent of neoadjuvant chemotherapy and radiation, now even a negative margin is enough and is oncologically safe for rectal cancer. Also, the surgical staplers, which has been boon to the colorectal surgeons, and this was brought by Ravage. I'll be coming to this in detail. Then rectal cancer surgery became more precise with the MRI, with the use of MRI in rectal cancer. And this has been possible to the Gina Brown group, who did the Mercury trials. And most importantly, it was the intuition of surgeons who thought that a rectal cancer surgery could be done in a safe and oncologically sound way, as shown by Bill Heald. So this was the Ernst Miles operation in 1907. It was a combined abdominal and the perineal approach, and you can see, and he took care of the upward spread of the tumor. And it was a wide resection, entire levators, the ischial fossa was removed, and it had its own morbidity and mortality. And the journey continued through Hartmann's procedure, anterior resection, low anterior resection, till 1983, Heald devised the TME. Heald was from a county hospital in Basingstoke. It's a small hospital, and he had the insight to think that rectal cancer spreads actively through the lymphatic and the venous outflow. And he also proposed, he also knew that there's a mesorectal fascia, and which by itself is impenetrable. And more so, it's more impenetrable by having a avascular plane around it, which separates the viscera from the soma. And how this separation occurs is by difference in embryogenesis. And it is the tumor, the rectum and the mesorectum has a common embryological origin, and it's a single lymphovascular unit. And this avascular plane beyond the mesorectal fascia can always be reproduced and can be created by sharp dissection. So it was Heald which proposed the TME, and probably one of the greatest contributions to surgery from Heald is about the TME approach, and it just needs a long pair of sharp scissors. So having the TME becoming the gold standard, people started trying to push the boundaries, and then came the intersphincteric resections in certain situations. You do extra levator APE, or even the lateral pelvic node dissection to improve the radicality of rectal cancer surgeries. So when you talk about intersphincteric dissection, it is actually certain tumors are which are just above the dentate line, which would traditionally require an abdominal pelvic dissection. And in order to conserve the sphincter, if the intersphincteric plane is clear, then you can go through the intersphincteric plane, that is between the external sphincter and the internal sphincter, and can do a partial intersphincteric dissection, a subtotal or a complete intersphincteric dissection, and have a coloanal anastomosis. And this is oncologically safe and radically sound. So this is one of the specimens of Dr. Deepak who had shared with me, and this shows, you see the first string from the after the mucosa is the internal sphincter, and then there is a fat, and then beyond that there is a the external sphincter. So the intersphincteric plane is beyond, just beyond the fat and within the external sphincter, and fat itself is an impermeable barrier and prevents the tumor spread. So intersphincteric dissection in certain situations are very apt, especially most importantly when you do a low anterior resection and you get a distal margin which is positive on frozen section, and you want to avoid an abdominal pelvic dissection. You can do, if you have technical expertise, you can do a intersphincteric dissection and thus preserve the sphincter. Patient will have Lars syndrome initially, but over the year, 1 or 2 years, they all become normal and have good continence rates. There are certain situations where the tumor is invading the junction of the levator to that of the external sphincter, and in such situation, if you do a traditional and abdominal pelvic dissection, you would go close to the tumor at that black arrow point. So in such situations, you will have a margin positivity and a high local recurrence rate. It was also found that APR contributed to most of the margin positivity as well as for the local recurrence rate. And to reduce that, extra levator approach, extra levator abdominal perineal excision was devised, where you go beyond and take the levators from its origin, and thus give you a good cuff of muscle as a third dimensional clearance. So here you can see the specimen, a conventional APR, where there is wasting just beyond the mesorectum. And in a Dilip specimen, you can see there is a cover of muscle over it, and there is no wasting of the specimen, and gives good three-dimensional clearance to the tumor. So Dilip is usually done in a the perineal position is done in a jackknife position, and you have to do a lower sacrectomy that is just above the coccyx, so probably at the S2 level to gain access, and then you remove the tumor on block with the levators. And it's also important the defect should be closed properly with some of the flaps. Either you can use a gluteal flap, or most commonly what we use here is an adipofacial flap, and it gives very good coverage, as well as has decreased the wound morbidity of this procedure. In fact, the wound morbidity of Dilip is almost close to nil with better approximation and using of good vascularized adipofacial flaps. So this is the schema which shows that when the lesion is above the peritoneal reflection, it is an anterior resection. Just below the peritoneal reflection, you do have to do a low anterior resection. At the rectal junction, that is when the levators join the external sphincters. It's a low and ultra low anterior resection. And when the intersphincteric plane is free, and then the tumor is juxta-anal, then you do intersphincteric dissections. And when it's beyond that, you have to do an abdominal perineal dissections. So now, increasing the radicality, people have thought about lateral node dissections, especially the Japanese are pioneers in this. And they found that up to 20% of the low rectal cancers, T3, T4, shows lateral pelvic node positivity. This decreases as the T stage decreases, and also as the tumor goes cranially. So in upper rectal, the incidence of lateral node will be around 3%. In a low rectal T3, T4 lesion, it will be around 20%. And so, and these are one of the common sites of relapses and also decreases the outcomes. So a lateral node dissection in low rectal cancer is advisable. Here we usually do when the MRI shows a definite lateral node or the node which persists even after chemo-RT, then we will do a lateral node dissection. But we don't routinely do, because most of the the radiation takes care of the lateral node in our scenarios. And Japanese, they don't use much of radiotherapy, so that's why lateral node dissection is more important in those situations. Now, advances in imaging, and it is the advances in rectal imaging by the way of MRI through the Mercury trials, which made rectal surgery very precise, just like a sarcoma surgery, where you already decide on the planes of your dissection pre-operatively. Here, the planning of surgery, the treatment planning, everything is done based on the MRI. And the MRI to be taken, all rectal cancers, MRI has to be taken. And this MRI is a plain MRI, and it has to be taken without any bowel preparation. So this is the prerequisites of an MRI, and say plain MRI. That's very, very important. So MRI in the MRI pelvis and rectum has defined a lot of things, like the T3 lesions have been defined as and divided into A, B, C, D based on its extension to the mesorectum. The mesorectal fascia has been defined, and mesorectal fascia involvement or threatened mesorectal fascia has been defined through MRI. One of the more important things is the extramural venous invasion. It's an independent prognostic indicator of distant metastasis. Intersphincteric plane has been defined, and juxta and supraanal positions of the tumor has been defined. I'll be coming to most of this in the subsequent slides. Now, a good MRI will help in defining the sphincter complex as well as surgical planning. You can see the red line, the horizontal red line is the level where the elevators bend down and join the external sphincter, the puborectalis link. And the red arrow is the levators at its origin. The white arrow is the intersphincteric plane. And based on the locations of the tumor to this diagram, you decide which surgical options are apt for the patient. So now this is a type 1 supraanal lesion, and it's very simple. You get a good mesorectum around it, and then you can do a low anterior section. For a juxtaanal lesion, where it is close to the intersphincteric plane but not involving, if you do a conventional TME, you might get a margin positivity at that lower end. So in such situations, or even the mucosal margin positivity, so in such situation, you can do a partial intersphincteric resection and get a good three-dimensional clearance to it. So now here's an MRI. So you can see the black line with the white arrow, which is the levators, and you can see the tumor above at a higher location. And this type of lesions, you can do a low anterior resection. When the lesion is just close to the intersphincteric plane, where the levators turn to join the external sphincter, this is situation if the intersphincteric plane is free, then you can do an intersphincteric resection. It may be a partial intersphincteric resection, or it may be a subtotal or a complete intersphincteric resection followed by coloanal anastomosis. These tumors involve the external sphincter, they goes beyond the internal sphincters and also involves the external sphincters, and this would require an abdominoperineal resection. The next tumor, which shows it involves the external sphincter, but it's also involving the levators at the white arrow. And it is these type of tumors which require a extra levator abdominoperineal excision, or the commonly known as Ilay procedure. You can see the extramural venous invasion, which are tongue-like projections from the tumor, and actually it traces to a venous origin. You can also see the nodes in the mesorectum, and this external venous invasion is a very important prognostic factor because it decides such patient. It says that such patients require chemotherapy and they are more prone to develop liver metastasis or other distant metastasis. So this is an independent poor prognostic indicator in rectal cancer. Now coming to the technological advances, because technology is very important, and I would divide this technological advances into the advances in staplers, then the minimally invasive procedure, minimally invasive platform of the TEM by BUS, and the laparoscopic and the robotic platform, which we are all now very familiar with. Now, staplers was actually made famous by Ravitch. Ravitch was a renowned pediatric surgeon from US. He was born to a Russian father. And this Russian connection is very important because in 1958, he visited Russia, and the Moscow Research Institute, Surgical Research Institute, was doing a lot of research on experimental surgical apparatus. And his visit to one of the centers in Kiev, the thoracic surgery department, the professor Nikolai showed him a stapling device, and he was able to buy that device and bring it to US. And by 1967, a startup company by US Surgical Corporation with Dr. Ravitch as its advisor started marketing the staples and has revolutionized GI surgeries and made anastomosis very simple, and also had decreased the leak rates considerably. Then there was in 1980s, there was this young German rectal surgeon who wanted to make rectal surgery very minimally invasive, and he's devised this BUS platform, which is a proctoscope which improves the visibility, also improves the working space endoluminally. And this was mainly used for rectal tumors which are benign, and also T1 lesions which are appropriately staged. You can do a transanal resections and get away with a major abdominoperineal resections or major low anterior resections with a stoma. And then technology developed. You develop the transanal minimally invasive surgery, the gel pod, which is a disposable device, and this is now commonly used for transanal surgeries. Then there is a hybrid procedure with which is known as the TATME, where it's a transanal TME, where it's a bottom-up procedure, where the anal procedure is done through a resectoscope. And this is actually the schema of the Color 3 trial, where the blue line shows the dissection areas of TATME, and the black dotted line shows the conventional TME. It is hypothesized that the TATME will have better margin of resection, the mesorectal margin, because at the point where the mesorectal tails off, you tend to have a positivity. So, but by doing a TATME, you will have a wider mesorectum, and also your distal resection margin would be very well defined in TATME. However, we have to wait for the Color 3 trial to know whether this is really a new kid on the block. But there have been reports from Scandinavia countries where this procedure has been banned because there is increased local recurrence. But this is still being carried out in Netherlands, and we are waiting the Color 3 trial. Now there are advances in adjuncts to surgery, which is also very important. And I would divide them into radiotherapy, chemotherapy, and targeted therapy. Radiotherapy of late, it's not an advances, but then with change in philosophy from a long course radiotherapy to short course radiotherapy for various reasons. Short course radiotherapy is given as 5 into 5, 25 gray, 5 fractions of 5 gray for a total of 25 grays. You finish your radiotherapy schedule within 5 days. It is more easier on the patient economically. And also there are a lot of theoretical advantages of having reduced distant metastasis to some immunomodulatory effects of this high dose of radiotherapy. And 5 gray or 25 gray short course radiotherapy is equivalent, radiobiologically equivalent to the long course radiotherapy where you use 50 gray. So our institute now we use almost for all cases short course. Very occasionally we do long course, but otherwise almost all our patients get short course chemoradiotherapy, short course radiotherapy. Chemotherapy has advanced with different regimes, and this is mainly to improve the pathological complete responses. And people have added targeted therapies again to improve the pathological complete responses. Now, coming from sphincter conservation or the organ conservation, we are now thinking about organ preservation, where the whole rectum and the anal complex is preserved. And to understand this, we should know certain terminologies. What is CCR? CCR is complete clinical response, and PCR is complete pathological response. And there's also should understand what is tumor regrowth and tumor recurrence. Tumor regrowth is that when the patient is put on observation, the tumor develops at the site of the previous tumor. It's not tumor regrowth, it's not recurrence. The tumor recurrence is that you get tumor in the loco-regional areas, then that is more problematic and ominous, and that is known as tumor recurrence. You should also know something about total neoadjuvant therapy, and which is where you give chemoradiotherapy or you give radiotherapy and then complete the chemotherapy, which may be either 6 cycles of FOLFOX or 5 cycles of CAPOX, and then you take the patient for surgery. And this has got a lot of theoretical advantages, that you improve the pathological complete response rate. Also, your time to reversal of stoma is much reduced, so that patient need not be on stoma for a longer time. There is a concept of watch and wait policy as popularized by Habagama, which I will be coming in detail. And some things about the predictors of PCR, which is also very exciting, because if one can predict a pathological complete response pre-operatively or pre-treatment, then that such patients can be treated aggressively with neoadjuvant chemotherapy and consolidation or induction chemotherapy after radiation. And if you get and such patients can be kept under observation, and you can have organ preservations in this. So to predict the PCR, there are a lot of molecular biology tools like KRAS and P53 mutations, which can predict poor response to chemotherapy and radiotherapy. There are also certain MSI positive tumors on IHC, which predict that these tumors will respond better to chemotherapy and radiotherapy. There are also certain tumor infiltrating lymphocytes, which can be tagged with CD8 and detected by CD8 IHC, and such tumors can do respond very well to chemotherapy and radiotherapy. And these subsets of tumors can be aggressively treated in a neoadjuvant fashion, and then you can keep them under observation if they develop a complete clinical response. So what is complete clinical response? The first picture shows there's a total disappearance of the tumor. There is a white scar, a few telangiectasia, but a near complete response has a small ulcer, but then there is no definite lesion. And an incomplete response, the definite lesions are present. So it's very important to understand this. So by endoscopy, you see a complete clinical response by endoscopy, distal rectal examination, and an MRI. So in endoscopy, which shows a flat white scar, telangiectasia, no ulcer, no nodularity, a normal distal rectal exam, and a MRI which shows no lymph nodes and mainly a dark signal, T2 dark signal, then these are complete clinical response. And such CCR does not necessarily extrapolate into a complete pathological response. That is very important. So what is watch and wait policy? This was a concept which is popularized by Habagama and Habagama group, and they actually did a retrospective analysis of some 265 patients who deferred surgery and they had complete clinical response. So with a median follow-up of 57.3 months, they found that only 3 patients developed distant metastasis and 2 patients developed local recurrence. And the 5-year survival was 100% and disease-free survival was 92%. And this gave impetus to the watch and wait policy. And probably one of the ideal situations would be a lower rectum CT2 lesion, which otherwise would require APR or APR. In such situations where you can give neoadjuvant therapy, and if they develop a complete clinical response, you can keep them under watch and wait policy. This is evolving. It's not a standard, but then this is a certain situation where you can do. The pathological complete, with the advent of radiotherapy, initially we used to give long course radiotherapy, and then the pathological complete response was 18%. To improve the pathological complete response, people started using neoadjuvant chemotherapy along with it, and they improved the pathological complete response to 38%. So what does PCR determine? PCR determines that such patients have very low chances of local recurrence to the tune of 1 to 2%, and the chance of distant metastasis is also less than 4 or 5%. So these are such patients, even if you such pathological complete responders, even if you observe, or even after TME, there is no difference in, even after surgery, there is no difference in outcomes. So now people are aiming at developing, at getting a more pathological complete response. So if there's a large database where patients who have been kept under watch and wait policy, they show a regrowth to the tune of 17 to 25%, 2 years, and almost 90% of the regrowths occur within 2 years, and up to 95% of the regrowths can be salvaged without any without jeopardizing their long-term outcomes. That is very important. And over the follow-up, most of the complete clinical responders have shown only around 8% of distant metastasis. So it's an impressive way. Probably in future we would be thinking more of watch and wait policy. Now now the Habagama group is planning, is doing studies on planned watch and wait policy, where till now the watch and wait policy was in patients who deferred surgery because of various other reasons. But now there are certain situations where they started doing as a planned procedure. Like in a T2 lesion, you want to preserve, you want that patient to preserve the organ. Then you increase the radiotherapy dose to 54 gray as to the conventional dose of 50.4, and you give chemotherapy. And then if they're clinical responders, keep them under watch and wait policy. This is a planned wait and watch policy by Habagama group, which is now being practiced in Brazil. So to conclude, TME is the gold standard. There's no doubt about it. Minimally invasive techniques improve the quality of life, also the quality of life. And based on the oncological outcome, there are controversies, and which is itself a matter of debate. But important thing is that in the low rectal cancer, open procedure scores over the minimally invasive technique. Again, it's a controversial topic. SCRT, or the short course radiotherapy, is radiobiologically equivalent to LCRT. It's also more logistically convenient to the patient and has got a lot of theoretical advantages in terms of decreased distant metastasis rate due to the immunomodulatory effects of the larger radiation fraction. Intersphincteric resection and DLAPE are the new surgical armamentariums, which are very handy, which are handy to improve the sphincter conservation rates, also to increase the radicality in certain situations. Total neoadjuvant therapy has great potential, and if suppose we can predict the PCR in patients pre-treatment, then it would be great. Watch and wait policy or the protocol is evolving, and the TATME, we have to wait the Color 3 trial, and which would say again, then we'll have another new tool in our surgical armamentarium. So I thank you, and I would be happy to take any questions.
Thank you very much, sir. Floor is open for discussion. Good evening, sir. From Mayank from Maulana Hospital. Just a few stoma, that will reduce the preference for making the stoma, or because after post radiation, how is the anastomotic rate, leakage,
No,
and
I didn't get your question clearly. Can you just repeat it?
yeah, regarding the short course
Yes.
radiotherapy,
Yes.
you are telling about the stoma, right? It may be
Yeah.
included.
Short course radiotherapy will also have a stoma. In short course radiotherapy, we operate either within 7 days, or in certain situations we wait for 7 to. It's a delayed procedure in elderly patients. The stoma would be definitely there in short course radiotherapy. And the wound morbidity is there was a concern about wound morbidity, but then it is almost negligible.
In spite of that, negligible, you would like to put a stoma.
Yeah, even in short course, you will definitely put a stoma, because radiobiologically it is equivalent to a long course radiotherapy.
Okay. Thank you.
Right.
So anything you can highlight on the post surgery chemotherapy?
I didn't get the question.
So that surgery, which regime would you prefer, right? Like that.
After surgery, it's actually the medical oncologist perspective, and then most of the time it is Fox. And if suppose if it's a neoadjuvant, I think the easier way would be a capox, capecitabine with oral capecitabine with oxaliplatin in a neoadjuvant setting. But most of the time we don't practice long course radiotherapy, so it's a short course radiotherapy. We don't use chemotherapy along with it. Most of the chemotherapy are in the adjuvant setting, where we use Fox if it is indicated.
Thank you. Question from online viewers. Okay, sir. Hi, sir.
Thank you.
Please wait. Please wait.
Dilip, I had 2 questions still.
Sir. Yes, sir. Good evening, sir.
How are you?
Hello, sir.
And VGF inhibitor potential camp.
VEGF inhibitor, sir. Sir.
Can you hear me?
No, okay. Now I can hear, sir.
Yeah.
So what was the question?
ദിലീപിന്റെ ചാറ്റിലേക്കാ ക്വസ്റ്റ്യൻസ് ഇട്ടേക്കണേ അതാണ്.
കണ്ടില്ല.
Okay, no problem.
എനിക്ക് ഇത് എങ്ങനെ നോക്കണ്ട അറിയില്ല, അതുകൊണ്ട് സാറേ. ചാറ്റ് ബോക്സ് എങ്ങനെ? കിട്ടി. What are the indication? VEGF inhibitors are usually given in metastatic settings. Hello?
Any more questions? Hello, Moshe.
Yeah, yes, sir. Siddiq, sir.
Where are you operating?
Yeah.
Where is the operator?
Good evening, teachers. Today, presenting an unusual case of rectal sheath abscess, a case report. History: a 50-year-old female hailing from Malappuram. She is a known case of type 2 diabetes mellitus, systemic hypertension, and hypothyroidism on medical management. Presented with abdominal discomfort of 6 months duration and central abdominal pain with fever for 2 weeks without any bowel-related symptoms. And on examination, patient's vitals were stable. Tenderness in the central abdomen and just above the umbilicus, and with an area of induration of approximate size 6 into 8 centimeter, just above the umbilicus. Rest of the abdomen and systemic examinations were within normal limits. And on investigating the patient, USG abdomen was consistent with foreign body granuloma, and CCT showed the possibility of an infective collection in anterior abdominal wall with no intraperitoneal extension. And blood investigations, TC, CRP were evaluated. Then coming to the management, she was posted for exploration under spinal anesthesia. On exploring, there was an abscess of size 80 to 10 centimeter deep to the anterior rectal sheath above the umbilicus, more towards the right side, with a bone piece of size 4 centimeter penetrating into the rectus muscle. Drainage of the abscess along with the foreign body removal done, and wound debridement was done. And wound was made to heal by vacuum assisted closure, and patient is discharged with home based vacuum dressing on post op day 5 with healing wound with good granulation tissue, and on follow up wound closed with secondary suture, and now the wound healed complete. This was the CT image showing the foreign body. It's actually abscess collection, and on exploration, we could get a one piece of size about 4 to 5 centimeter. And coming to the literature, GI perforation resulting from ingestion of foreign bodies is uncommon with a less frequency of less than 1%. And chicken bone penetrating the gastrointestinal tract extending into the rectal sheath is extremely rare, and in a review of English literature revealed only one such case. In that there was a stitching needle was penetrated in the similar way, and it's presented as rectal sheath abscess. Coming to the conclusion, rectal sheath abscess is usually initially diagnosed as rectal sheath hematoma, and surgeons can minimize delay or misdiagnosis by maintaining a high index of suspicion for an occult retained foreign body in any abscess cases, and considering the etiologies other than rectal sheath hematoma, if the patient has signs of infection, then leukocytosis or progression to peritonitis. Usually, ultrasonography is to diagnose foreign bodies that are missed by CT, and timely surgical consultation is needed for these patients. Thank you.